Yes.
Okay, good morning to everybody. Sorry for short delay. So welcome to IPS session. We are going to speak about chemical peels, and specifically today we are going to speak about a combination with different technologies with chemical peels. Our first speaker is the respectful dermatologist from India, Mukta Sajdev, and she is going to speak about neuropeels for melanin-rich skin. Please.
Thank you. Good morning, everybody. Welcome to IMPAS. So let's kick off. I am going to speak about new peels. I'm going to try and change your thought process on chemical peels. So we used to say this: chemical peels are like your relationships, timing, depth, and aftercare. We then said that chemical peels are like dating. Go too deep, go too fast, and you'll regret it because your skin will remember your bad decisions. The new world, 2026. We have colored peels, we have specific area peels, we have newer peel techniques, and we have home use peels. But what is the 2026 new thought process? The real innovation is not a new acid, it's a new philosophy. We are going to talk about controlled injury to melanocyte modulation. The goal is no longer to make the skin peel. The goal is to make the skin heal beautifully. So number one, the shift from exfoliation to pigment pathway engineering. Historically, peels created injury, and they relied on epidermal turnover, and we used to measure peels by exfoliation. Today, we measure peels by preservation. Preservation of pigment balance, barrier function, and patient confidence. So the emerging paradigm is the peel plus melanogenesis modulation plus inflammation control plus barrier restoration. So many pigment experts now view the peel as a drug delivery system and a signaling event rather than just the primary treatment itself. Tranexamic acid, cysteamine, azelaic acid, topical antioxidants, and pigment suppressors are increasingly integrated into the protocols. So what's your thought direction? The future is not stronger peels. The future is smarter melanocyte signaling. In melanin-rich skin, the future of peeling is not deeper penetration, but greater precision. Number two, the rise of triple acid and hybrid peels, specifically designed for skin of color. So we're moving away from the single acid peel systems towards the combination systems. For example, mandelic salicylic, mandelic citric salicylic, low strength TCA plus pigment suppressors, and sequential layering of peels. The literature shows that skin of color studies have encouraging results with triple acid combinations, especially for acne and PIH, while minimizing inflammation. So the best peel in skin of color is now the one that removes the most skin. It's not the one that removes the most skin. It is the one that leaves the melanocyte undisturbed. Number three, tranexamic acid is increasingly becoming the hydroquinone alternative. So the conversation is that global peels are combining acids with tranexamic acid incorporated. It's being used for melasma. It's being used for recurrent PIH, hydroquinone-resistant pigmentation. There is a better tolerability, and many pigment specialists are now considering tranexamic as a central component of melasma protocols rather than just an adjunct. So what is the pearl to think about? Will tranexamic become what hydroquinone was in the 1990s? Just some food for thought. Number four, regenerative recovery after peels. Now, this is one of the hottest aesthetic trends globally. Instead of focusing only on the chemical peel, exosomes, growth factor systems, PDRNs, the regenerative biologics are being investigated as post-procedure recovery tools. The evidence is still evolving. Many experts are still very, very cautious, but regenerative aesthetics are becoming a major discussion topic worldwide. So whether it's a trend or a controversy, are exosomes the future of post-peel recovery or the next PRP? Food for thought. Number 5, melanocyte-safe peeling. Now, new emphasis on inflammation minimization, barrier preservation, and reducing melanocyte activation. These are terms you're going to hear across the board for the next 3 days. And we are thinking about this when we're doing chemical peeling rather than simply selecting the right acid. So the concept resonates strongly because PIH, or post-inflammatory hyperpigmentation, is fundamentally an inflammatory disease. It is not a complication, it is an inflammatory disease. So the pearl, the most successful peel, may be the one that generates the least inflammatory signaling. Tinted photoprotection is becoming part of peel therapy. The procedure doesn't end when peeling stops. Visible light has emerged as a major contributor to pigmentation disorders in darker skin. The use of iron oxide tinted sunscreens, the use of visible light pigmentation protection, and pigment-specific photoprotection is now an essential part of peel outcomes. The most important step in a peel for melasma may be the sunscreen that you prescribe afterwards. AI-driven skin of color assessment. No talk today is complete without a mention of what you're doing for AI. So it's an indirect trend for peels. There is major growth in skin of color image databases, dermatology vision language modules, AI-assisted pigmentation assessments with specific focus on improving representation of skin of color globally. The trend, objective PIH scoring, melasma tracking, personalized peel selections. The most cutting-edge concept is micro-peel protocols. So this is a new trend emerging. Instead of one medium-depth peel for skin of color, clinicians are performing multiple superficial procedures. They're lowering the inflammatory burden on the skin, shorter downtime, and cumulative pigmentation improvement. The pearl. The philosophy is actually borrowed from laser dermatology. Many gentle interventions outperform one aggressive intervention. And this is very specific for melanin-rich skin. So we have a shift from exfoliation to pigment pathway engineering. We have the role of triple acid and hybrid peels specifically designed for skin of color. Tranexamic is becoming the hydroquinone alternative conversation. Regenerative recovery after peels, melanocyte safe peeling, tinted photoprotection, part of your peel process, AI-driven skin of color assessments, micro-peel protocols, the new cutting-edge concept. So we're moving from controlled injury to intelligent intervention. Thoughtfully protect the skin while achieving your transformation. So we're in a new era. The evolution is no longer from superficial to deeper peels, but from controlled injury to intelligent intervention. Success is no longer measured by the amount of peeling you achieve, but by the precision with which you improve the pigmentation, but you also preserve barrier function, you respect the melanocyte biology. So the expert future peeler, if that's you, then you need to understand the complex interplay between inflammation, pigmentation, photoprotection, and regeneration. It's not just about peeling. In skin of color, the excellence lies not in how aggressively you treat the skin, but how thoughtfully you protect the skin while achieving your transformation. So, I conclude, in darker skin, every peel is a conversation with the melanocyte. Wisdom lies in speaking softly. Thank you very much.
Thank you very much. I think that you need to leave, right? Mukta, you need to leave for your next session. So if we have any questions? It's not a question, but I think that what is nice about IMCAS, because in every location we have different population. So I think it's amazing, because for dark skin, something completely different is required. Listen, we all have the skin, epidermis, dermis, hypodermis, but the behavior is different completely. Therefore, what works for me in my country does not work for you in your country. And if I apply multiple superficial peels to a wrinkled European skin lady, she's not going to benefit. If I perform a deep peel for young dark skin patient, it will not achieve what she's looking for. So I think that we need to keep it in mind, because we live currently in a global world, and we tend to adopt trends and understandings from different countries. So always ask yourself, is it right for my patients? Thank you so very much. Thank you. So our next speaker is Fotini Bayorgo from Greece. She's just retired of being the president of IPS. And she does not, she still needs this supporter here.
Of course.
So she's going to speak about chemical peels for trick indications.
I will give a special credit to IMCAS Asia for that. And Paris should know better. Ah, yes, yes. Yes, I wish I had that experience, but not yet. This is me. Okay? Got it? Okay. So now I need, yes, and I need the lecture. Here, this is it, here. Yes, this is good. I don't have a lecture. So I'm going to show you some aggressive, let's say, procedures. And before telling yourself this is not for me, hi, Ilan. I have to tell you that I'm coming from Greece, which is not that hot, but it's much more sunny, around 11 months around the world. So I also practice on a sun-tanned skin, dark, not all of them are dark, but like 60% of the population we work on have like a phototype 3 or 4. And of course we're lucky and we work also with phototype 1 or 2, but 60% of your practice is not a small number. Thank you so much. Good. Okay, let's go. So, nothing to declare. So, when we usually give lectures, what they ask us is, what is your favorite pill, or which is the best pill? So, there's no favorite pill and there's no best pill. We have some basic principles, and of course there are no safe pills, because there are no safe medical procedures. And so, as chemical pills are medical procedures, we all know that there are no safe chemical pills, but they're efficient chemical pills. So always we're based on the differential diagnosis. I'm a dermatologist, so I'm used to that. So first of all, you define the indication, what we want to correct. Then it's how can I correct this indication. So this is how you choose the right pill, because you cannot treat a deep indication with a superficial pill, no matter how many of them you will do to your patient. And of course, we know that the deeper, the better, but deep sometimes means your patient should look like that, and not all the patients want to go into the tunnel of deep chemical peeling. So what we do, we segment our pills so that we can perform them in the clinic and give our patients an option that works the best and hurts the least. So acne scar, for me, and I hope for the rest of the world, is a very tricky indication, and that's why I included in this lecture. And no laser treatment so far, and I feel that you may agree, can address acne scars with a single procedure, or even with multiple procedures. What we have is fractional laser, we have Pico, we have fractional RF, but we need multiple treatments. Let's see what we can do with chemical peeling. So here you can see a young lady, different kind of scars. We can see ice pick scars, and we do cross method for here on the forehead. Ice pick scars are these like very tiny scars, like you create them with a toothpick. And then we did for her deeper scars, cross method with phenol on the malar area. And what we see dermoscopically is how we destroy the skin barrier, how we do perform correctly the cross method, and how we can prove that by biopsy. So we always do biopsy. We want to prove our results. This is evidence-based medicine, and chemical peel is a medical procedure. This is how she looks, and this is not contamination, or this is not impetigo. This is bismuth gallate powder. We apply, it's yellow, we apply post-peel, and this is how she looks like for a few days until this crust falls. And then she will have a redness. She knows that will last like from 2 to 4 months, usually around 2 months. But the patients say, redness I can cover, scars I cannot cover. And you can see dermoscopically how nicely the skin is recovering. And look at this and tell me if you know any other procedure that can address and have this result with one single session. Photoaging. Photoaging for me is another very tricky indication, because patients don't want to peel. So if they don't want to peel, we cannot remove everything. So we inform them, and they will let them decide how far they want to go. They want to go all the way, or they just want a glow. If they want to get rid of their dull skin, then they have to use medium chemical peeling. And this is a result. By the way, this is a very unhappy patient of mine. She didn't see any result. We all have such patients. And this is a very happy patient, traveled from Australia to Athens to get peeled. And this is the before, and this is the after with a single procedure. And this is what a medium depth chemical peel can do. This is salicylic acid 30%, followed by TCA 35% publication I've done with Dr. Marina Landau. And you can find it easily online. And again, talking about tricky indications and chemical peel devices, melasma for devices is a no-go, especially in darker skin. And if you want to peel a patient with melasma, you have to be very, very careful, because melasma is regarded part of the aging, not just photoaging, and is a chronic disease, so we need to maintain the result. And if you want to peel this patient, you either have to go superficial or deep. Never estimate medium peels, TCA peels for melasma, especially in your skin. And this is the first time in history we are talking about the cure of melasma, because we usually treat melasma. So our dear colleagues published a really breakthrough on publications treating with deep phenol chemical peeling patients for aging issues, found out though that they got rid of their melasma almost forever, for more than from 5 months to 15 years. So you can see different phototypes, from 1 to 5, for 1 to 4, and here you can see what deep phenylcrotonol chemical peel can do on a segmental basis. You can see we used hydroquinone there. First line is hydroquinone, and then what segmental phenylcrotonol pill did. Again, first line hydroquinone, and then complete clearance with deep chemical peeling. Another patient, another patient. Third tricky indication, perioral wrinkles. And I know that you inject a lot, and I know that the best option is either a little bit of cannula or blanching technique, but you know that you have to inject these patients again and again. But look at these patients. This is how they look after segmental deep phenylcrotonol peel. You can see the liquefaction of the skin, and this is immediately after the peel. This is some like days later. You have to get into the tunnel of the deep chemical peeling to obtain these results. And these results are for more than 10 or 15 years. So you have a happy patient. That has to go through all this. You have to pay a toll to be happy in this life. This is a small toll, okay? Another patient, again, this is the toll you have to pay. But, you know, when you go to the hairdressers, you look like, you know, you have foil in your hair. When you dye your hair, you don't look good, okay? Peeling is the foil of the peeler, okay? So you have to look bad to get better. And here you can see segmental chemical peeling, deep perioral peeling, and then blending with a medium peel around, and you can see the difference, okay? No laser, one like for 2 or 3 euros. I don't know how it's in baht, but it's cheap. And then dark circles, another very tricky indication. Where is the pigmentation? Is deep. Can we work it with some peels that are in the exhibition that are perioral peels containing azelaic acid? No, you cannot bleach your eyes with Skinoren. So what you want to do, deep chemical peeling. You can see how they look like Rocky Balboa, but then you can see how nice they recover. And if you are wondering about your skin color, I can show you, this is a little bit of surgery on top. We remove parts of the skin. This is the publication, and this is how they look immediately after. You see, no surgery, just peels, no surgery. And this is a lady treated in Santorini, which is really sunny. I have a clinic there, and this is her nice result. So choose the right peel for the right indication and be brave. Explain to your patients what they can get. You can see before and after without surgery. And there are a lot of impressive peels that we post on social media, but you have to choose the right peel for your patient. If you want to learn more, please become a member of the International Peeling Society. All these ladies here can share their tricks and tips with you. And I would like to invite you on May next year for SCARS meeting in Athens, Greece. Thank you so much, and stay in contact.
Thank you very much. Any questions for this peeling tricky areas and tricky indications? Okay, think about questions.
Okay. Our next speaker is our beloved friend and very experienced peeler, Atula Gupta from India. Atula is going to talk to us about optimizing sequential peels in dermatologic and aesthetic indication. So it's very important to know that all these peels share medical and aesthetic indications, always being medical procedures. So, Atula,
is it okay if I speak from here?
you can speak,
Yes.
or you can all even sit on us.
I think there are some free
Gupta. The one above. No, the one below.
Yes.
Right?
Yeah, that's right. So, a very good morning, and like we all discussed, that we have to do peels depending on our patient, depending on the color of the skin. I'm from India, I'm going to tell you about a technique that I do commonly, which is sequential peels in treating dermatologic and aesthetic indications. I have no disclosure. Now, reiterating from our first speaker, again, what is the clinical concept of peeling? Understand this is more than an ablative technique. This is an inflammatory reaction and dermal stimulation to modify skin. This is the most important when you're peeling. Let's come to my talk. What are sequential peels? A peeling technique in which 2 peels or more can be applied sequentially. The action of first peel is stopped in the same session, followed by another peel, which can be terminated or left on as a leave-on peel. Why do we want to do sequential peels? Do we want to do them? Let me tell you why. First peel can enhance the penetration of the second peel, so you get a better peel depth. Different chemicals, understand, have varying pK, different acidity. So using the right strength of each molecule or chemical in a single composition sometimes may not be practical. You need heterogeneous molecules to work on different targets in the skin. Something works on melanin, something works on dermal pigments, something works on moisture. So this is the classic Monit's work, Gessner's plus TCA. Dr. Fortini talked about it. This is the foundation of sequential peel theory. And these are some of the indication where I use sequential peeling. Your acne, PIH, melasma, a lot of lichenoid disorders we see, like lichen planus pigmentosus, photoaging, rejuvenation. We do a lot of keratosis pilaris. We see a lot of insulin resistance with acanthosis nigricans. We see cutaneous amyloidosis a lot, and of course, periorbital melanosis. Now, they're widely used, but I found out that true evidence pool is actually small. We don't have a lot of evidence pool. These are true sequential studies. There are 5 core studies in total. GA followed by TCA in photoaging, GA followed by TCA, studied in melasma, Gessner's followed by TCA, studied a control trial in acne, Gessner followed by TCA in acne scars, and Gessner followed by resorcinol in photoaging. So there's a lot of studies, but there's not so much evidence pool. So this is one of the studies. It was done in 2020, where glycolic 70 was followed by salicylic 20, once in 2 weeks for 6 sessions in mild and moderate acne types. And this was compared with doxycycline alone. So talking about acne. So glycolic 70 was followed by SA20. The comparison was done. It was said to be equally effective in reducing grading, lesion count, and interleukin levels. This is another article on combination chemical peels, again reiterating that combination peels have better therapeutic response when done correctly versus single peels. Let's come to what I use most commonly in skin of color, dark skin, type 4, type 5 skin. Sequential salicylic acid 30% or salicylic acid 20 or 30% is a very forgiving peel. I follow it up with glycolic acid and kojic, which is a mixed combination peel. I prefer gel-based peels because the penetration is even. You can use it for acne, you can use it for acne marks, you can use it for PIH. Salicylic acid is oil soluble, penetrates, and preps the skin. So understand this can be your priming peel, and then you can use a glycolic, low strength, always low strength. You're doing 2 peels, improving texture and pigment. Let's come to, I want to show you some of my patients. This is acne with post-inflammatory hyperpigmentation. I did a salicylic acid 30% peel, self-neutralizing, but you wash it away and follow it up with a glycolic low strength alone or a glycolic kojic combination. In this case, these are multiple sessions, no oral medications except topical acne control agents. This is the other side. These are sequential peels. Again, a combination of salicylic and glycolic, multiple sessions, topically treated with retinoids, adapalene. I use all of that like everybody. close-up, multiple sessions, some of the scars are lifting. As you can see, this is a salicylic acid. Always use salicylic first. This is acting as your priming peel. The second one will act as your therapeutic peel for your marks. But remember, they have to be low strength when you're treating darker skin. Comedonal acne, I do a lot of salicylic first. Follow it up with a tretinoin. Leave on peel. This is multiple sessions. Again, these are all multiple sessions. You're not going to get magic in our skin because we don't want to peel too much and land up with PIH. This is, again, same acne with acne marks. A lot of results, acne, other side. Another patient, inflammatory pustular acne. Best first agent to apply, salicylic acid, most forgiving agent for skin of color, followed by glycolic kojic. Again, treated with only topicals, maybe oral antibiotics, but no oral isotretinoin here. 2 sessions only, multiple sessions. Similar, so I'm just going to run through this, multiple sessions. You can get complete clearance here if you do. Similar results. Again, acne with erythema, acne with erythema. Let me come to the second combination that I use. So first we discussed salicylic followed by glycolic, right? This is the second combination I use a lot, sequential salicylic followed by lactic. And again, I prefer gel-based peels because they evenly penetrate the skin. Salicylic acid is unclogging your pores. Understand this. Oil control, sebocytic activity, and lactic acid, when you have dry skin, when you have sensitive skin, when you have acne excoriae, when you have mature skin sometimes, acts as a humectant. Soothes the skin, hydrates the skin, absorbs water, and fades marks because it's a melanin-inhibiting agent also. This is what I did. Another of my case, typical acne excoriae, acne with severe PIH. This patient is, scratching, salicylic 30%, same session, 4 to 5 minutes. See the endpoint. Always see the endpoint. It's not, there's no fixed time. You see the endpoint, and then you leave on lactic acid for 4 to 5 minutes, couple of sessions, it hydrates the skin. Lesser number of sessions needed versus a single peel. And then, Dr. Mukta talked about it, using double agents. Triple I've never used, but this is another result. This is the front of the same patient, salicylic with lactic acid. Again, dry skin. He has been scratching it. It's a little excoriated, so works very well. Acne with scars. Dr. Fortini talked about it, but yes, there is one study with sequential peeling with Jessner's and 20% TCA versus 20% TCA alone for treatment of acne scars. I have just this result for now, which is multiple sessions improving acne scars using only peels versus lasers and devices. So when you have peels, I think it's a very strong armamentarium for you. It is cost effective, it is affordable. And that's why we love it so much. Let's come to difficult indications. Melasma, freckling, acanthosis, lichen planus pigmentosis, amyloidosis. These are difficult. Look at this. This is cutaneous amyloidosis, macular amyloidosis on the back. Very hard to treat, but you can treat it with laser, you can lighten it up. But again, here, the first peel, glycolic acid 70%, helps in penetration of your main therapeutic peel, which is 15% TCA and 9% phenol combination. So first glycolic, watch your endpoint, should not be blistering, erythema, wash it away, and then put 15% TCA and 9% combination. This is 2 sessions. So again, like I discussed, GA, rapid keratolysis, stop at endpoint. Second peel, your therapeutic peel, medium depth injury, targets the pigment. Again, with TCA here, stop at light to medium frost. I'm talking about my skin color. Do not go into a compact frost, right? This kind of peels have downtimes. I'll talk about it. TXA was discussed by the first speaker. Great peel usage for melasma. TXA typically 8% is available. Okay, to peel or not peel, yes, to peel or not peel melasma, very hard, but we always counsel. This is only hydroquinone and glycolic and kojic acid, followed by 10% TSA and tranexamic acid, 8% peel. Similar, again, it won't disappear completely. This is what we expect. Day 2 to 4, micro peeling. Day 4 to 6, peeling subsides, mild residual pinkness. And day 5 to 7, full recovery. Patient should be off all actives. Yeah, this is the mild pinkness. I mean, the barrier repair has to be very strong over here in this skin type. I want to show you this. This is AN, acanthosis nigricans, heart condition. Treated the acne with salicylic acid in the first peel. Again, a combination peel followed by 15% TC and 9% phenol. And this is what I did. So the first peel was 8 minutes, neutralized. Second peel, stop at the lightest frost. This is what I did, 3 sessions, 6 weeks apart. And temporal hyperpigmentation, again, difficult. You can use Q-switch lasers to treat this. But if somebody wants peel, GA35 followed by TCA phenol combination. You can just use TCA phenol also, but sometimes I wanted to experiment with this patient, so I left the second peel for a very little time. Expect downtime here. Just 1 session, lichen planus pigmentosus. TCA 15% and phenol 9%, just 1 session, forehead. Again, lichen planus pigmentosus. And these are my last slides. Rejuvenation, very simple. Sometimes you can combine kojic with lactic, immediate after shine. So lactic acid with ascorbic acid immediately after. Tanning, very common indication, right? It comes to our clinic a lot immediately after. And under eyes, like Dr. Fortini mentioned. Again, you can use 2 superficial combination peels over here. I use glycolic immediately followed by retinol. Left it on for a few hours, 4 to 6 hours, improves the rugosity under the eye. And in conclusion, it's a versatile technique, but it's not for everybody. It is something you will have to pick up slowly, do it, carefully looking at the endpoint. Always never do deep peels in sequence. Superficial sequential peels are safe. They carry lower risk. Different low-strength peels can be combined. Avoid deep peels in sequence, like obviously you cannot. And I thank you very much.
Thank you very much. We'll keep the questions to the end. And our last speaker is coming from India as well. And she is going to speak about, let me see, it was a peeling. It's not a peeling, it's peeling. So it's a controlled peeling in today's day with 0 downtime. It's like a magic, right?
Okay, while she's setting up, I'm always nervous to speak in front of Marina. You remember, I was like, I'm still am, a huge fan of hers. I think the first lady ever to come in and just show power and say, we know it.
Yes,
and
you can do it. You can do it.
Was-
Listen, you cannot see it, but it's like there is a step here behind the podium.
Come on, you
so
can't say that.
every lady which is stepping up becomes immediately higher. So this is
Okay, so we've been today fortunate to get our lectures and our experiences shared by some really eminent doctors who have real experience in practice also and not just the theory. What I am going to do in the next 10 odd minutes is tell you how we can only sometimes do superficial peeling. That's all is what we can afford. But yet we have to give efficiency, right? Like we most often say that very procedures which can give you great results in one sitting are the same procedures which can also give you great complications in one sitting. So likewise, when you're trying to do something very mild with 0 downtime, your results may also be very little. So you need to set the expectation right and then see how you combine to actually meet the expectation of the patient also. So that's what we're going to run around today on. So firstly, what am I peeling for? We need to understand that. Most common indications are, I want a more even tone, more rejuvenated face, a lighter skin, maybe acne, like most people spoke, PIH, texture changes, all of this, yeah? So also there is a peeling that we do to simply hydrate. Did you know your peeling can also improve your skin's slight texture? If it is over dry skin, you can still peel to get some hydration on. So Atula just spoke about sequential peeling, and many people spoke about double peeling. So the result that I got from there to there is beautiful, isn't it? Yes, we agree? But I got that at the cost of this. Now this, in India or in most of our practicing patient, is not acceptable at all. So she went through the trauma of this to get there. She was very happy when she got there, but in that journey, through that journey, hand-holding is not easy, right? So how do you still get from there to there without this phase is what we are going to talk about today in the next 10 minutes. Now, I'm Indian, and all I can afford is a superficial peel, right? Why? Because I'm all shades of brown, I tan very easily, I burn as well, as against many Fitzpatrick scale, I get both, tan and burn. I have sunshine 12 months of the year. That's beautiful in India. We believe sunshine gets good luck. So all our houses are east-west facing and big windows, so a lot of sun inside. So there's nothing like, oh, stay indoors after a peel. That doesn't work with us. I don't like sunscreen. It's not in my DNA at all, no matter how many times I tell my patients. So there was a recent study which was published which said there is a 75% awareness of sunscreen, but there's only 25% compliance. Isn't that so funny? And then for us, beautiful is still fair, unfortunately. Melasma runs in our families. You touch me and I PIH, right? So then how do you work on an Indian skin? What does zero downtime mean? Which means I don't even want redness. Forget PIH. I don't even want redness. I don't want visible peeling. I don't want any irritation on my skin, and I will not take care. Meaning to say, I will not do any post-care care that you have told me. So which means the entire onus is on the practicing clinician to let them go as if nothing were done, but still give them result. Now, how do we do that? So what are my questions? What should my questions as a practitioner should be? What is my target tissue? Like every speaker has been telling you so far. What is the target tissue is something that you really first need to take care. He's okay. So what can I combine it with to give the optimum result? What is the result expected by my patient and by me? If you can chart down these 3 questions and write the answers, then you choose your modalities accordingly. Now, the tissue could be anything, right? Just the dermis, the epidermis, the subdermis, but can I go to the dermis? I can't. So how do I combine that with? Can I go to the subdermis? Absolutely not. So what do I combine with? Keratinocytes, easy peasy, still can manage with superficial peeling. Melanin, only the clumped ones which are ready to die and fall off, not the ones deep down. Fibroblast, I can't do it with superficial. Collagen, elastin, ground substance, no way with a superficial peeling, right? So then I need to see how I should combine. Now this is what I do. Even skin tone, pigmentation, skin lightening, pH. Does this make half our practices? Right? Half the practices between these. So what do I then do? I do a peeling with combination like Mukta rightly said. So I do a little bit of a phytic, a little bit of an Arbutin, a little bit of a Kojic, mix them all and apply for around 20 minutes. So I've taken away the clumped melanin, the dead cells from the top, which act as a barrier. That is all is what I'm doing, literally prepping my skin with this peel and not necessarily expecting a long-term result. The result that I can get only with this peel may last around 7 days to 10 days. But what am I using this peel for? So that I can penetrate deeper, so that I've taken away the barrier on top, so that I've taken away the clumped melanin on top, and now I can penetrate deeper and give actual result with my equipments. Again, even with the equipments, my energies are toned down to low because I PIH, right? So we tone the energies down. So I do a Q switched. If I need more even tone from the top, I use a CO2. If I have a little more lighter skin tone and is okay with a slight downtime, then I do a CO2. Why do I do a peeling before CO2? That's my prep for the skin. So my chances of PIH is a lot lesser then. So these are the various lasers that you can combine them with. Now, this is very common in my country. I don't know about the rest of the Asian countries. Perioral and periocular pigmentation. Very common, right? How many of you see those cases very commonly in the OPD? Okay, so most of the Asians see it, and it's not just Indians. So what do I do here? I again do the peeling, because that, like I repeatedly will tell you, acts as a prep for me and reduces the downtime or the chances of PIH. So I'm using a very mild peeling. And then in the first case, I've used more of a Q-switched, but I've also used a non-cross-linked HA, which then gave me a little bit of ground substance, a little bit of healing, a little bit of biostimulation for the skin to heal well. So that, in fact, was my hero and not the peel. Peel was just an entry to me. Yeah? But in the second case, I had to use a filler in combination with peel and Q-switched, because the darkness there that the patient complained did not just come from skin surface. It came from shadowing and lack of support underneath the skin, which had to be given no matter what you did, unless you know to peel like Fontini and Maria here. Yeah, so then you have to do something to it. So what do I also do when people come to me saying, I just want an even skin tone and just a happy skin? With the peeling, I do an RF, which is just kick-starting. Because my peeling is so superficial, I can't guarantee them anything with one sitting. So I'm calling them literally sometimes to peel every 10 days. While I do that, I can combine an RF, so at the end of 3 months, she gets a beautiful result. So this is where counseling and setting the expectation right with the patient makes a huge difference. You also end up doing some medifacials. All of this combined together hydrates the skin. We know the glow and the beauty of the skin does not come from one factor. Hydration becomes very, very important. This is where peeling combining with mild procedures really help. Now, what do I further do with peeling? Take away the top barrier, and then I inject. So you could inject anything, from a skin booster to a combination of peptides, glutathiones. You can run an exosome on top of it. You could use microneedling. All of these in combination with a superficial peel gives you great results in terms of skin texture and hydration, especially for acne scars, open pores, very oily skin, seborrheic skin. These works really, really well. Now, aggressive acne, the first picture that I showed you is what I would treat before with sequential peeling, double peeling at the same time. Put one peeling and put another peel on top of it. Put a liquid peel and a gel peel on top of it, or a home stay peel on top of it, like yellow peels. But they used to give me a lot of downtime. So what do I do now? I do less of a peeling, but more of other things to calm the inflammation down, other things to penetrate deeper into the sebaceous gland, which will be either microneedling, IPL, all of that to give results such as this. Again, of course, medication, IPL, all of that. I know people are taking pictures, but may I please request you, all of these pictures of my patients, I haven't even watermarked, and I don't have permission to put them out in the open. So it's okay for an educational seeing, but please, please do not put them anywhere, yeah? Thank you. Now, this is a very, very tough skin, which happens lots in India. They do a lot of actives on their own and come to you very inflamed, and you just don't know what to do with it. So very mild sequential peeling with IPL gives me a great result in patients such as this. Then I graduate them to MNRF, because I know basically the problem is the overactive sebaceous gland. So I need to address that. So these are a few more cases. Again, very difficult PIH. Ideally, deeper peeling, medium depth peeling would really work well. I can't afford it. So I do a superficial peeling. I do extractions if it is active, and comedones in situ. I kind of remove them. I do an NDAG, and then skin boosters, all in rotation. And this is, again, the big G factor, which we are all scared of, right? Glow. Everybody wants a glow. And how do you get that glow? Becomes very difficult and not an easy thing. I combine multiple things. So the big takeaway for you is many, many series of sequential, the superficial peeling with a few facials and biostimulators is what works. If you like biostimulators, you could do that if the skin is very dehydrated, patient has a very lean face. But if there are a lot of Asians who have already a full face, and when I do biostimulators, even the short term of water retention kind of filling, they don't like it. Then I do energy-based devices. So you choose from an energy-based device or a biostimulator to stimulate their collagen. Do we do things to the lip? Yes, of course. I love to peel the lip. Again, very superficial peeling, followed by a Q-switch laser, gives wonderful results. You could also do microneedling in whatever form you like to do and do some exosomes, skin lightening, whether it is melasmas, vitamin C's, whatever you like to pour on top of it, that you've created a channel now. Yeah? So those really work beautifully well. You could create a channel, pour them in, massage them out, and that kind of penetrates and gives you a good result. Now, the last thing which troubles all of us, but the most difficult thing that every speaker has spoken to you is about melasma. What do I do in a melasma? Earlier, I used to do the phenol peels and TCA, like exactly Fontini said, but look at the percentages of what I'm using, yeah? It's like a baby percentage is what I'm using, because that's all is what we can end up doing. I do that combined with Q-switch. My Q-switched game changed after a few papers last year that I read, where the Q-switched on a brown skin, or rather any skin with melasma, you go very low fluence and multiple passes. Whatever machine you have, lesser than 1 joule, multiple passes is what you do. And then at a very, very low fluence, you can actually do a 532 as well. Just a single pass. So that works brilliantly well. These are a few with just peels. This was a histopathology confirmed LPP. Very, very superficial peels, but it took me around 3 years to get here. Yeah? Now, can complications happen when you're superficial? Of course it can happen. Look at that patient there. Now, she was treated elsewhere with a medium depth peel, which rightly so, just now, Fontini said, never do that for a melasma. A medium depth peel, and if you see white confetti marks, that is a Q-switched after a medium depth peel with the triple combination. What is a triple combination? One of the trio is steroid, right? So that was given for a long term, and this is what she came to me with. This is what she came to me with. A very difficult case. Again, nothing aggressively was done, but everything was just too much, just a little too much, and this is what happened. So that is what you need to understand. Which tilt is just a little too much? A 10% left, and you're left with this. Yeah, a 10% right, you may get less results, but you can still do multiple sittings. But a 10% left, you can never afford in a brown skin because it leaves you with this. It took me 3 months to get her back to this with a whole lot of yet peeling, but which was very superficial. And then we did a lot of biostimulators here to rejuvenate her skin. Barrier repair is what was the most important thing for me to first do, and then go back to peeling and Q-switch to give her just this. So this, my dear colleagues, is my talk. Thank you very much.
Thank you. Thank you for your amazing talk as usual. We have 5 minutes for questions. So I will ask you, I mean, if we have 3 out of 4 speakers, so, because, you know, you present, we are trying to educate, right? And yet we are sharing our experience, which is very, very, have a lot of information. And I just want people leaving this room to choose a single peeling agent just to start with. So what is going to be your choice? A single peeling agent and a concentration. I know that it will address only minor, but I want them to start doing chemical peels. So how should they start?
I would love to answer your question just as much as that, but because we are doing superficial, single peel may not give you anything. You still do the glycolic, pyruvic, mandelic, TCA, salicylic, phenol. Ground rule is don't go beyond 15%. Is that okay?
Beyond?
15, 1.5. Or maybe, especially TCA and phenol, not even above 10. So if you can stick to them being below 10, and the second most important is not just the percentage of the peeling agent, the most important thing I would say is the pH. The lower pH really burns and kickstarts a lot of inflammatory process, which becomes difficult for you to deal, and that is what gives you pigmentation. That is what gives you PIH. That is what gives you the skin irritation, which later they go home and apply an active as simple as, oh, but we put only HA, we put only CA, vitamin C, but that adds on to that inflammation.
Yeah,
What
the
about
pH of vitamin C is 1.5. So keep it in mind. We are afraid of peeling solution. We are not afraid of vitamin C. The
Yes.
pH,
What about
vitamin C is very, very acidic. So it can cause PIH actually much faster than glycolic, salicylic acid.
Yeah, so along with the percentage, you have to look at the pH. Very, very, very important.
Atula,
And the
you need a mic. You need a mic.
I wanted to answer the same question because I do a lot of single peels also, and I agree with me. It is salicylic acid, which is the most forgiving agent when you're using a single peel, pseudofrosts, and then you just, I mean, I've never seen, you still have to be careful, but you don't really see burns with salicylic acid.
Yeah.
It treats everything.
Yeah, so just if you need to get out of this room with a single message for Asian or dark skins, salicylic acid, you can get high percentage, like 30% alcoholic solution of salicylic acid. It's very, very safe. It's efficient for multiple indications. It does produce desquamation. Keep it in mind. It's not lactic acid. They will peel. So this is something that your patients need to know. And yet it is very, very safe. Yes, please.
Yes, I just want to clarify. You said that the endpoint for the salicylic acid is a light frost.
Like, yes.
Okay. The second question is, have you had any allergies? Patients who are allergic to aspirin. Do you ask that for people who?
No.
No,
No.
So even if you're allergic to aspirin, you don't see any
Yeah.
problem with it.
No.
no.
And
Yeah, small correction. It's not a frost, it's pseudofrost.
Pseudofrost.
You can wipe it out. So, frost,
Just
real
a
frost
slight-
is
slight
coagulation.
pink, a
Yeah,
slight-
you have a little bit of whitening, but you can wipe it away.
it's a very
So
light pink.
yeah,
Okay.
yeah.
No pink. It's white.
It's
called
white.
frost white.
Very
and
light,
then you wipe it
yes.
off.
There's no coagulation like what you see in trichloroacetic
right,
acid.
right.
You just see the pseudofrost, which you remove.
Okay, okay. I just want to clarify something because you're talking about sequential peels, right? There have been so many products now, usually from Spain, who have a combination of 3, 4, 5, 6 peels. So are you talking about single agents that you layer, or are you talking about some special products that already have the 3 or 5 combination? I just want to clarify that.
Yes, I typically do it,
Thank
and
you.
I like that question because I use these peels. Normally, they're combined. I just feel it's easier, and they're combined in a simpler gel-based nanosome technology, etc. formulations, which I'm a little scared of the alcoholic preparations when I'm doing sequential because they just penetrate so fast. So for me, maybe the first peel would be a single solution, but the second one, I like to use them in combination. Like what I mentioned, the TCA phenol was already prepared together. Like 15% TCA already combined with 9% phenol.
I think that you need to be very careful about these combination solutions that have multiple ingredients that actually, usually there is no any scientific support for the superior efficacy of the combination. It's very rarely that you will find a good article, scientific article, actually showing that there's some kind of advantage. And again, keep it in mind that what works in my clinic will probably not work in your clinic because we are treating different patients. So even there is this scientific publication, just be a little bit more critical. Look what was who were the patients being treated? Is it relevant to your practice? So for beginners, I always tell you, just start with a single ingredient solution and see what you can achieve. Because for single ingredients, we have a very, very wide database showing the experience in different countries, different populations. So they are much safer, in my opinion. Then you can play around with these combination solutions. And when you have enough experience to cope with complications if they occur. So
Thank you, thank you.
And another important thing about combination pills is that this is for the industry. It's on the bottle, it's not indicated how much of which. So it says mandelic, citric, kogic, 30%. So you don't know which one
one
is.
is how
Yes,
much.
yes. So
I just want to, again, we're talking about beginners. So I do prefer combination-wise to use, for example, microneedling followed by superficial peeling solution. Microneedling published it together with don't remember the name. Anyways, because the idea is to create fractionally deeper penetration of superficial peeling solution. Because if you microneedle and apply like glycolic acid 30%, which is very safe, or lactic acid 30%, you can get your solution in the dermis, and we showed it in the scientific publication. So think about it. Do not trust anything that you have in the bottle. If there are multiple ingredients, as Foteini said, you never know what is the concentration, how the ingredients actually interact in between them when you apply it on the skin. What are the risks of PIH? So all this is very, very important, especially when we are treating darker skins.
I
Yes,
just
please,
wanted
last-
to add, sorry, just one thing to what Marina was saying. When you do a microneedling, like she said, and applying the acid, please understand it's getting down to the dermis and no more just the epidermis. So you must be prepared that somebody will PIH. So be very, very mindful of that. In my experience, what has worked really, if you want to get more efficiency out of your peeling, is one, sequential peeling. First, single ingredient, as Marina said, and I stand now agreeing to what she says, that salicylic acid could be a great thing, because everything today, whether it is PIH, whether it is acne, whether it is seborrhea, everything starts from your oil gland, right, the sebaceous gland. And salicylic works brilliantly with it. So no matter what your presenting condition is, a salicylic acid would do great. If you want to go one step higher, you combine the salicylic with maybe a mandelic, with maybe a pyruvic, with maybe something else. So that's your second step. The
Retinoic.
third step could be probably do an energy-based device, like a Q-switch laser, like an erbium glass, which does not allow you to penetrate too deep, but you know you've just passed that one layer down. The next would be a microneedling thereafter to get a little more bold once you're experiencing what's happening. By then, you'll also understand how much of your post-care your patient is actually following. So these are times you buy the time to judge the patient also in terms of compliance.
I have one very practical question. Every day we encounter patient with like skin type 4-5 with mixed type of melasma.
Correct.
And you are planning for 4-5 sessions of peel. Then
Yes.
how do you, what is the exact way that you plan?
Oh,
Like,
good question. I was waiting for someone to ask this. So when I combine multiple things, it all looks nice and dandy when I just put them all together on a slide. But how do you actually plan it in a clinical practice? Of course, my first consultation, I am only doing applications. So if there is a melasma, then I'm only going to start off with maybe sunscreen, which is the most important thing. A combination of skin lightening ingredients for the night could be azelaic acid, kojic acid, tranexamic acid, a combination licorice, just some calming agents is what I give at the night. Many a times I give them only calamine lotion in the evening if I see allantoin in the evening, if I see that they're really sunburnt and have melasma. So I'm trying to just heal the layer first. And a lot of moisturizer to hydrate the area, because most melasma patients don't come to you as virgin patients. They've either gone somewhere or with an internet, they would have done something to themselves. So this is something I do in the first. Second round, or in the same round, I may start a tranexamic acid if they are medically indicated towards that, if there's no contraindications. I also am big on supplementation. So I give them antioxidants. Anti-inflammatory is something that I really, really love doing. So that's something. Later on, I can tell you the brands that I use. So this is something that I really like. Then I start them off with a mild peeling first. Maybe it's just a glycolic or a pyruvic or a TCA or a phenol under very, very, very low doses. I use combination peeling. So I apply that. Do not keep it more than 15 minutes initially. Then I slowly expose the contact time to around 30 minutes in after 15 days. And I do the peeling once in 15 days because in my mind, you're giving 7 days for the layer to kind of come back, another 7 days for it to heal and be happy before you insult it again, right? So that's what I'm doing. After 2 or 3 peelings, and I know my patient is compliant, doing everything nicely, I don't see any erythema, I'm not seeing any further inflammation, I introduce my Q-switched under very, very low fluence. I do a couple more sittings with peel and Q-switch once in a month. Then I add biostimulators so that I'm also healing the skin from within, because most melasma happens with age of about 40 or 45, mostly coinciding with their menopause or with their oral contraceptives. So you also will do well by replenishing their collagen, elastin, ground substance, so the skin starts to heal well. So I introduce it then. So this is how I go over 3 months, very slowly introducing one by one. And at the 3rd month, I have all 3 going, or all 4 going, whatever I've decided. And it's usually at an interval of 15 days each. I do 2 at a time. I don't do all 4 at a time. So this is how I sequence it.
so basically prefer like multiple
Gradually,
types of
yes.
peel.
Yeah, melasma is a chronic disease, so it requires chronic treatment. And never forget.
Energy device like you use instantly after doing the peel after.
Instantly after doing the peel.
Okay.
Immediately after that, I use the Q-switched.
And never forget tinted sunscreens.
Yes.
If you don't use tinted sunscreens, your patient will develop hyperpigmentation.
Yeah. What I also do is double sunscreen these days. I tell them skip the moisturizer, never mind. Use one sunscreen and then put a tinted on top of it. So that really works because none of us really apply how much you should apply, right? We all tell them two finger, two finger. We ourselves don't apply two finger. It becomes very sticky. So, yeah, exactly.
Thank you so much, and join IPS.